Welcome, everyone. We'll get started in just a moment. Actually, given that we're 3 after the hour, why don't we get started? Good morning, good afternoon, good evening, everyone, wherever you're joining us from. We're so excited to have you here with us today. Welcome to our 7th Listening and Learning series session. This listening and learning series began in April of last year and is really focused on highlighting lessons learned from the COVID-19 vaccine rollouts around the world through live events like this one and also a podcast series. Next slide, please. Next slide, please. So just before we begin, just some quick rules of the road, instructions to please mute yourself when you're not speaking, just to make sure that we don't get too much background noise. Please use the reaction buttons on the bottom of your screen or raise your hand if you'd like to share a question. And please do engage in the chat dialogue. And if you can share now your name and where you're joining us from, that would be fantastic. So next slide. Before we get going on today's session, I just wanted to also highlight that we have a new episode for our podcast series that will be released in early June, hopefully next week, perhaps the week following that, called the COVID Response in West and Central Africa, Approaches, Learnings, and Reflections. So tune in to hear from 2 WHO Afro staff members who will share reflections from the COVID-19 pandemic response in West Africa. Today's conversation, so next slide, please, will be a continuation of our previous session last month that was focused on forecasting and demand planning for COVID-19 vaccinations. And this session will answer some of the questions that you brought up in our last session and include practical tools, considerations, and recommendations for COVID-19 vaccine product selection and opportunities for financing demand-related efforts. We are very thankful to have our 4 panelists with us here today, including back with us again, Benjamin Schreiber of UNICEF, as well as Stacey Nobler, Vice President of Vaccine Innovation and Global Immunization at Sabin, and Ben McCormick. And Stacey and Ben McCormick will walk us through the Priority Vax tool, which is focused on supporting countries as they select which products are right for them. So with that, I will hand things over to Ngok, who will moderate today's discussion with our panelists.
Thank you, Jen. And welcome to everyone who is in the audience. And please do say where you're from. In the chats, just your name, where you're from, as well as perhaps the work that you do. I see some folks from Italy, Pakistan. Welcome to all of you. We've assembled some great people to talk to you today, and you'll recognize some of the names if you were with us in April. We convened the Boost community to discuss COVID-19 vaccine demand planning and product choices, to share tools and learnings for immunization professionals. That's what we were talking about in April. And during that session, we offered practical tools, recommendations regarding vaccine product choices to optimize portfolios. And panelists also provided insights to support countries when making choices of COVID-19 vaccine products and the size of the portfolio of the various products according to comparative advantage for different uses, of course. And we had a spotlight on Uganda, and that episode is available. You should see the link on the chat shortly if you want to have a look and see that episode at your own time, of course. So today's session is really a continuation of that conversation that we had. And we're glad to have Benjamin back to talk to us about financing. And also Stacey and Ben to talk about Priority Vax. So without further ado, I'd like to invite Benjamin to share some thoughts in answering some of those questions that have already been highlighted by Jen, like what financing mechanisms are available to support demand efforts at subnational level, which tools are available, to develop budgets for demand forecasting, and what are some best practices, and also what resources are available to determine priority settings in resource-constrained environments. Benjamin, please take it away.
Thanks a lot. So I will talk a bit of context and then go into more detail on financing and hope, but I'm happy also if this is not to the level of detail that you needed, please ask more specific questions. Let's get going to the next slide, which is kind of, as you know, this inequity that we still have in terms of how many doses have been administered worldwide. And a lot of countries still under 20 and 10% in terms of COVID vaccine coverage. And demand generation is definitely a key priority in many of these countries because, I mean, apart from ensuring that there's access to them, but we do have to deal a lot with demand and community engagement to make sure that the vaccines go into the arms in the end. Next slide is then an overview of what we do. I'm part actually of the COVID Delivery Partnership, which is like an interagency group made up of people of Gavi, WHO, UNICEF, but as well as IFRC is part of it. And we work with donors and African CDC and other partners. And our role is really to help even the lowest coverage countries, of which in the beginning of the year there were 34, to increase their coverage and make sure that the especially highest risk populations get access to the vaccine. We do this by providing 4 types of support: providing funding, technical assistance, demand planning, and political engagement. And I will talk today about this delivery funding. But to note also on the technical assistance side, we are working a lot on with the experts on demand generation, and have asked UNICEF to take forward a summit which will be organized on demand generation in the coming weeks, to talk about best practices, case studies, and what have we learned so far on demand generation for COVID vaccines. Next slide. So, like I said, in the beginning of the year, that's kind of, you see that the lowest number, you go from 34 going to 18. We had 34 countries with coverage below 10%, and the average vaccination coverage in these 34 countries was around 3%. So, as we move forward throughout time, we now see that it's 10%. So there's an increase in the coverage. We don't attribute it all to the delivery partnership, but we do hope that there's some support of that was provided that has had an impact. But also what we see is now 16 countries have crossed the 10% coverage line, which is not a great line to cross. I mean, it's just like a first step in the right direction. But many of them are now moving towards 20%, and we see some of the coverage really improving. But at the next, if you look at the next slide, if 16 countries have crossed, that means 18 countries have not crossed that line. And this is a list of these countries. Geographically, a concentration on the African continent, but not exclusive. There's a lot of countries also in the Middle East, some and Papua New Guinea and Haiti. So you see here the coverage, how many people were kind of reached, but what's maybe 3 important points. Healthcare workers, very far on the right-hand side, have not been reached with high coverage. The elderly populations have not been reached in great quantities in all countries. And then you see this kind of fading gray circle next to the country names. That means that these countries have sort of significant humanitarian situations. And basically 14 out of the 18 countries have really significant humanitarian challenges. So really community engagement is going to be absolutely vital. And working with NGOs and CSOs in these countries is going to be very important, as well as with the humanitarian actors. Next slide. So I talk a bit more on how we work and what we do and what's our objective for on the funding and funding delivery. And really the objective is like, now that vaccines are available in large enough quantities to vaccinate really large quantities of all populations worldwide, we need to make sure that funding is not the next big problem that hinders the rollout. So, and not only can't it not hinder the rollout, we need to make sure that funding is accessible and can be deployed quickly. We've heard for a long time funding is available, and World Bank has put significant resources there, but it doesn't mean that it's available where it needs to be made available. So in the health facilities, in the remote rural areas, or in some urban slums, the funds may not reach these areas yet. So that's what we also need to make sure. But even at the global level, we need to make sure that funds are dispersed quickly. So 3 things we're doing. Number 1, provide transparency on who is funding which countries. We have set up sort of coordination meetings to engage and align the funding and really kind of set up a system as a 3rd point on how we deploy funding, at least across WHO, UNICEF, and Gavi, trying to get funding out within 10 to 15 working days. Next slide. So the first of all is a tracker. It's of course has an acronym, the C19 VFM. Don't ask me what that all stands for, but for sure I think the vaccine funding monitoring database. Yeah. So if not, it will be more or less this, because it's basically a big database that tracks across 28 sources who is providing how much funding into which country for COVID vaccine delivery. And we're tracking this across 132 countries, and tracked so far around 3 billion of funds. And so this is a list of donors, so that so we've got bilateral organizations that provide us update from Australia, Czech Republic, Japan, New Zealand, but also the different COVID, COVAX and Gavi funding windows, and some multilateral development banks and UN partners and private foundations. So we're trying to really capture all of this as much as possible. And if we forgot something, then please let us know. We're trying to really have a comprehensive view, because it's important. The funding, this kind of funding landscape is the most complicated I have ever come across in immunization, and I looked at this for a long time. It's good, there's a lot of funders, but it's really complex to access these funds, and how to access it, where. Well, at least now here is some donors, and maybe to give you some guidance, some of these donors are more prone towards funding demand generation. So I think if you want to go through bilateral channels, for example, I know that Canada is keen to work on this. USAID, CDC is working on this. Germany is just releasing funds to a lot of countries. I think they're going to look into this, etc. So I think this already should give you an idea of where to look. Next slide. I'm trying to make it as concrete as possible here. This is the funding that we have across UNICEF, Gavi, and WHO. So we have so far looking at about $2 billion, but Gavi has also successfully finalized their latest round of fundraising for COVID vaccine delivery with another $600 million. So we're trying to track across these 3 agencies really where the funding is, how much funding we still have in sort of flexible funding. So we've deployed most of the 2 billion already. That is at country level. We still have 131 million that's fully flexible, that could be deployed anytime. As new funds come in, again, we're filling up the spot and then deploy it to where it's needed. Next slide. So each agency has a slight different approach to funding. At the highest level, Gavi has a real very clearly outlined application process where CSOs and collaborators can work together, and that will be reviewed by Gavi and then approved and dispersed. UNICEF has an emergency fund that can deploy funds, but these needs to be requested by the UNICEF country offices. But funds could also go to partners. WHO also has funding, and they have raised a lot of funding and provided as well through their process. So WHO and UNICEF is not an application; it's actually like requests. And then the African CDC has set up their Saving Life and Livelihoods process with the MasterCard Foundation, where they have identified certain institutions and technical expert that will provide the work on the ground, and are negotiating these budgets with the governments and the technical partners. They're doing this across the 55 member states. So that's maybe again a little bit of more detail, but can I ask me if you have more questions? Next slide. So what have we done in terms of success story was Chad. Chad had a need. They had a new minister, and the new minister wanted to kind of roll out the vaccines quickly, because the rollout was kind of like sort of not very, put this way, they weren't not, yeah, it was hanging, like it was behind that of some other countries. And the new minister really wanted to ensure that they have the ability to do a first round campaign before the start of Ramadan. But then they came to the Gavi SCM and said, like, we want to do this, and we need money basically next week to start doing this. And we need about, $4.9 million. And then we looked at all the different funding sources that we have. And then actually WHO and UNICEF provided some funds really within a few days, and then worked with the World Bank and the Gavi Secretariat also to reprogram some of their funding. And really all the funds were made available within sort of 10 working days. And that really enabled that this campaign was launched, and was a success. 1.6 million additional people got vaccinated quickly. And this kind of things that we're trying to do and to achieve with this funding alignment. We have to overcome these most urgent funding bottlenecks that countries are facing so that they can support the rollout. Next slide. I'm nearly at the end, don't worry. What we want to really achieve is that countries, that we simplify also the programming of these funds. In the moment, every donor is asking for their own little budget template, and some of them talk to each other, but some of them don't. So, one calls it outreach, the next one calls it just service delivery, the next one calls it campaign. And then you don't know what you're actually funding, and then one donor doesn't accept the budget of another donor. And so country colleagues are really complaining that they are spending a lot of time filling out the same information on different templates. So the suggestion was that we move towards a one budget vision, and then have a comprehensive budget for the whole country, and then donors pick up certain slices of this budget and put their name behind it. And this way we see kind of who's funding what. But to get there, we needed to align at the global level first on the costing categories that we have done now. But most importantly is also making sure that the donors are going to use this one budget, and that countries have this one budget in place. So the next slide is then some of the principles. So here's like some storyline on the budget, but here's also some principles of how to develop these one budgets. Again, it must be, the government must be there, must be leading it, must have a clear time frame, clear links with the operational plan and the targets that they want to achieve, clarity in terms of what they want to spend funds on, and sort of integrating this with other costing work that's maybe ongoing, and then a reflection of available sources. We are not anymore at the point in time, I think, where people will consider sort of solicitations left, right, and center that we had in the beginning of last year, where that created the mess we are in, where you know, it made sense because it wasn't clear where you would get funding from. So everybody wrote to everyone about getting funding. But I hope by now that we're trying to streamline this process and then support and have a more coordinated engagement. So one of these examples maybe is like Nigeria finished their planning of their micro plans at state level. They have identified quite a big funding need, but there's funding from USAID already at the country. There's funding from the World Bank already at the country. There's funding from some of the partners already at the country, but there's still a gap. So we were now able to identify a few donors that are willing to step up and step in to fill this gap. And I think that's the way how we want to do it, to simplify and get more clarity of who does what. I think that was my last slide. No, I think maybe a takeaway slide, one more. So key takeaways, it's highly fragmented, much more than usual, but we hope that the one budget plan approach will help to really streamline the process, make it better and clarifies who funds what. So we need to, one of my lessons learned is that we need to really simplify it also going forward, and you know, and some of these investments we do at a global level to align just on costing categories are actually really important. And finally, the last 2 points is like we really trying to have a coordination efforts between the bilateral donors that are coming in now into the countries and are working with their own implementing partners. It's especially Germany, USAID, but also France and some other bilateral donors, and making sure that the multilateral development banks are also engaged. And then what I struggle with is really to, I often, especially certain donors say me, oh, there is funding available, don't worry. But I say like, yeah, but there's no funding in this country for this specific campaign available. Oh, we don't know that, but there's funding available. Yeah, but that's still, if the funding is not there for this specific campaign, that's going to start in 2 or 3 weeks, you have actually a funding gap. So you maybe don't have a funding issue overall, but there are real short-term financing treasury issues where funding is needed. And I think really distinguishing this, like, oh, what's the overall gap, but what is the most urgent needs now, it has been really important, because often only a little bit of funds are needed to very quickly to kickstart certain priorities and activities. So I think that's where we continue to focus on these, while we're trying to manage the longer term funding gaps, also really trying to shoot down any short-term funding gaps we're seeing. Over.
Thank you, Benjamin. Very clear and insightful, as always. I want to bring in Stacy and Ben here to talk to us about Priority Vax. The question on my mind is, what tools can help us reach the country targets, some of which Benjamin was just talking about. And Stacy and Ben will help us answer some of those questions, like what resources are available to determine priority settings in resource-constrained environments. How can Priority Vax, this platform, help with reaching country targets? So Stacy and Ben, whoever's ready, please talk to us.
Hello. I don't know if Stacey's able to join us at the moment, so I'll turn my video on for this moment to say hello, and then I'm going to turn my video off because I don't have very good bandwidth. So, hello. So Priority Vax is a tool which has been built to help support priority setting and decisions around vaccination. And it's really a tool to try to open up how decisions are made and make transparent some of those tensions and debates that go on about different drivers of decision making. If you can move on to the next slide. So there are some basic principles that we have when making this platform. And key to us was having country ownership of the decisions. So it's very much designed so that you could use it and within country, and try to build your own base of evidence that's specific to your decision needs. So, for example, wanting to capture the local context that's specific to your country, or even subnational areas, and using data to drive the decision-making process. It's very flexible, so it can try to address lots of different types of question. And some of the questions that we have considered would include things like the choice of different vaccines or prioritization of different vaccination groups. So who do you allocate vaccines to first? And trying to make that process transparent and in a way that can then be communicated with other people. So going right from defining the question through to building an evidence base and then communicating that with the different stakeholders that are involved. If you can move to the next slide. So at the end of Priority Vax, you have a decision matrix. And here is a picture of an example of what that might look like. We have different vaccines at different rows, and each one has a little decision matrix table that lists the different drivers of our decision making, how the relative importance we gave to them, how we judge that importance or the evidence, and then a score. And the aim is to have this table, which is transparent and could be reproduced and communicated. And then this collates all of the evidence and some of those parts of the decision making which might not be necessarily empirical, because some of the decision making is about having qualitative judgments. And sometimes it's very difficult to capture those qualitative judgments and show how those influenced the decision making. And so one of the things we can do is to weight different drivers of things that are important to us. So here, for example, we've got different drivers that might influence our decision making, including the cold chain requirements, things like how long a vaccine dose is viable when it's kept on the shelf, the number of doses per vial, the training requirement to use a vaccine, something like the effectiveness of a vaccine, and in the risk profile of the population. So we can capture all of these different things. And then in the example we'll talk about today, we could consider how that might be relevant to different areas of the country. So different groups of people, either, for example, geographic groups or administrative units, and how we could repeat this exercise to say, is the same vaccine product relevant in these different populations? So Benjamin was talking about the demand planning and how you might select a different vaccine product for different needs and different contexts. So if you can move on to one slide. So the workflow for the tool is that we start by identifying attributes. And these are the things that we think are important in the decision making. Some of these might be quantitative, something like the cost per dose, which is a number that we know. Some of them might be more qualitative. So for example, a binary decision. So does it apply to this risk group, yes or no? Does it require a cold chain, yes or no? Or it might be more like a qualitative scale. So for example, something like vaccine acceptability. Would this be a vaccine which is acceptable to this population? And I guess at the start of COVID, we saw that with debates around the mRNA viruses, mRNA vaccines, which were a new technology. Are those acceptable to the population, or would a different vaccine formulation be more appropriate? One of the key things about identifying these attributes is understanding how you then judge the importance of the evidence against that attribute. So for example, setting boundaries. Is it more or less important that this has a high number or a low number? And understanding what constitutes success. Then for each of the attributes, we assign a weight. This is, I think, probably the most important part of Priority Vax. Trying to capture the discussions around the table to say, why is this attribute more important than another one? In quite a lot of processes, there is an implicit assumption that all things are equally important. For example, you might consider mortality rate as important as the cost of vaccine. That's probably not true, but it might be how the process assumes your weighting attributes. Within priority vaccine, you can change the attribute weights, and therefore have a discussion about things that are more or less important in the decision-making process. And then clearly communicate that at the end. So sometimes it's difficult to understand how a decision was reached. You understand the evidence that was collected, you understand the numbers that were drawn out from that evidence, but you don't then know quite how things were pieced together. And some of this is trying to make explicit the implicit biases that different people in the decision-making process might have. So the next part is collecting evidence. And for example, using something like a grade process to describe some evidence that's gathered from literature, or it might be taking evidence from different manufacturers about vaccine characteristics. And these are numbers that are put into priority vax. And the last part is that we get a recommendation. So this is a relative ranking of the different decision-making units. So in this case, vaccine products. And then that is packaged in a way that can be easily communicated and shared with others. So if you move on one slide. So the idea is we're going to have an interactive example of priority vax. I was hoping Stacey would be here to run it on her computer, but if she's not, I can try to run it on mine.
And I think that we might be able to do it on our end. Just give us a moment.
Okay, that'd be even better.
Liz, I didn't know if you wanted to try to do it or.
Yeah,
Actually,
I
great.
can definitely do that.
Thanks.
Hold on one second.
So Priority Vax is built as an interactive online tool. Users have different accounts. So, hi, so you're in it already, that's excellent. So if you can click on the analysis button on the left-hand side, these are all different analyses that we've run. And if you click on the top example, this is an example of selecting between different vaccine products. Each of these bars is a different product, and you can see on the right-hand side, there's a little description. It has the name of the vaccine and then some attributes that were selected. And the point here is that each vaccine product is given a score, and the higher the bar, the greater the priority. So what we'll be looking for is preference for one or two relevant to our population. In this example, we have 5 different attributes. We have things like the cost to administer a dose, whether it has an ultra cold chain requirement, what the shelf life is for refrigeration once you've opened the vaccine product, how much waste there might be, and the volume of storage required. So you can imagine that if you went to different populations, so different areas of your country, you might find that things like waste matters, because if the vaccine is packaged in a large quantity, would you be able to use enough of it up if you went to a rural population versus an urban centre? And so the way that vaccines are packaged might mean that some vaccines are more appropriate than others in different places. And equally, you might have different costs to administer if you're having to go to a sparse population or a dense population, or storage requirements in different places, and different access to cold chain. So here, for example, is ultra cold chain, but it might just be refrigeration. The whole point is that you would select attributes that are relevant to your context. This is very much an example, so we can change some of these later on. So having got this, we might say that this is the profile of vaccine selection for one population. And then if Liz can click on the reconfigure, which is down at the bottom, then we might imagine that we go to different population, we say, what happens if the attributes are different? So we keep the same vaccines, and then if you go to the attributes tab in the middle there, then we can change the relative importance, or the relative importance of our attributes. So for example, if you scroll down a little, we say that the cold chain requirement is less relevant, and maybe the shelf life is more important. I think you have to go up to the top, and then there's a little box to tick. If you go a little higher, then change this automatic weight. So we use a default weighting that says that you can just give the order of these, and that gives a rank importance. But actually, if we click on the little boxes to the side of each attribute, then we're able to change individual ones and say, right, the most important thing for us is going to be the cold chain. Or we can say that something like waste is going to be more important. And so the attributes will change around, and we can reorder them. So in fact, Liz, if you see the little 6 dots to the left-hand side, you can grab them and just reorder the attributes. And then we can give them a different rank that way. So again, if you click the automatic weight in the top left-hand corner, you can see this is very flexible in rearranging things or picking particular values. And here you can imagine you have your table of people who are making the decision, and you could have discussions from different experts who have different opinions. What you can do is begin to test individual opinions and a consensus opinion and see whether that would matter. So does it matter that one person thinks that the shelf life is most important and someone else thinks that waste is more important? And they have different predilections based on their backgrounds and expertise. So if you click reanalyze, by changing the waste, we will see a slight shift in the balance of these vaccines. So the first two both require ultra cold chain, but if we say that that's not very important to our decision making, actually they are prioritized a bit more than they were before. If you go back to reconfigure, we can do one other thing, which is to change the values. And in this case, this would be the evidence that links one vaccine to, let's say, a community. So we might say that some of these things come from information from, for example, Benjamin, who tells us the cost per dose, or whether it requires an ultra cold chain. And some of the things might be context specific. So within our community, we say, actually, the likely wastage is going to be higher. So if you talk to the people who are putting those shots in arms, then they might have a perspective on this community. It's going to be we don't have the storage for these vaccines. So we can change the evidence here. And perhaps, Liz, if you just play around with shifting some of these for different vaccines, higher or lower, and you can set the scales. In this case, it's a percentage scale. So it's 0 to 100, and some of the others have different scales. Then we can say, could we select a different vaccine product for this community? And again, the example of maybe urban and rural populations might say, actually, in this place, it's unlikely we would waste any vaccine because we can always find someone to give it to. Or you might say, by the time that we open this, we can't keep it viable long enough to give it a whole vial of doses. So the waste is going to be quite high. Yep, if you click reanalyze. So what we see here is that the first bar, which was the one that Liz was changing the most, has been prioritized down. So that is given less priority. So we would say that that vaccine probably isn't appropriate for this population. But you can imagine repeating this for different places and beginning to say, actually, that dose might be useful somewhere else. And so when you're making your application for which doses you require, and this demand planning, you can see that you might select some vaccines over others. If very quickly, Liz, you click on the details button, That generates a PDF that you can print out and share. It has the same little graph at the top. And then if you scroll down, you see these matrices. And these matrices give the attributes that we selected, their relative importance, how we judge favorable and adverse conditions. The value is the evidence that we identified. And within Priority Vax, there are ways to type in that links to the evidence, so you can link to sources of information, be that a paper or technical documentation for a vaccine. And then we have a score, and the score is calculated based on how important you think that attribute is and what the value was compared to this range of favorable to adverse. And so this unpacks the score that was shown in the graph. If you can close this report, there's a little cross at the top right, and then you go to the analysis page again. So if you click on it's the two little pages, just the right-hand side, there's a clone. So if you go up one to where we were, then what we can do, if you click that, yep. So this will make a duplicate, but what's nice here is it takes us right back to the beginning. So here, for example, you can see the different vaccine products. You can add more, you can take some away. You might, for example, even imagine adding something which is not a vaccine, or maybe a vaccine for a different disease in this population that you think is important for other reasons. And here we can add other vaccine profiles with that plus button, or we can change details of what it is if, say, the name isn't meaningful. And then, Liz, if you go to the attributes page, this is where we select our attributes. And again, they have this automatic ranking. There are many, many attributes which are built into Priority Vax, but you can always add your own. And so, yep, if you click that, this shows some of the built-in ones which are categorized that we have found are common to decision-making processes from lots of different decision-making groups and reviews of literature. And then in the uncategorized section are things that we have generated ourselves. So these, for example, would do things like the cost per quali rather than per DALI. They might do direct costs versus indirect costs. Things like disease characteristics. So when we were considering who to prioritize, we looked at the WHO framework for allocating to different groups. And you could score the population based on properties of the disease rather than the vaccine. And so we have lots of different attributes, and you yourselves could add more which are relevant to your particular case. And that's the beauty of this, that you can always add more and change them. So if you cancel out of here, then at this stage we can, let's say we're all part of a community making this decision, then we could come to a consensus weighting, and we can also start from somewhere and give it this relative ranking. So the order in which we've put these gives an automatic weighting, and we can edit that as we see fit. So then, Liz, if you go to values up at the top, this is where we enter evidence. And so we would add citations, which is the next tab, and we could say that the evidence for, so here we have a link to each of the, or to different parts of the vaccines and their profiles, and you can cite your sources, which is important for the communication. I shall wrap up. So you see in the end result, so if Liz clicks back on analyze, that takes us, oh, sorry, I was thinking analyze at the other side. That then completes the analysis and gives us this ranking. But I definitely want some questions if you have some.
Ben, this is brilliant. If I'm sitting in, as I am in South Africa or Kenya or Uganda or Pakistan, as some of our audience members are, and I'm organizing around, trying to reach country targets, this is a very useful tool, and a useful organizing tool like that. So thank you for all those insights and for walking us through the Priority Vax tool. I want to turn my attention to the audience now. Karen thinks it's very cool. I agree, Karen. Do you have questions or insights that you'd like to share with the people that are here today? Questions perhaps for the panelists, Ben and Benjamin and Stacy as well. Please just either raise your hand or just type in your question in the chat box. And while you do that, I just want to ask our panelists, how can COVID-19 vaccination campaigns promote routine immunization and strengthen life course immunization? Some of the tools that you've shared, some of the insights that you've shared, how can we tap into that to promote routine immunization and strengthen life course immunization? Let me start with Benjamin and then go to Ben.
Yeah, I can answer this, and sorry, I've got a bit of background noise. Maybe I'm not going to go on my camera now. The everything we do has to make sure that we do not take down routine immunization, and we have seen that COVID has had, of course, a major impact on the routine immunization. And some, as we know, sort of large campaigns can also have major impacts on the ability of health workers to provide routine immunization. So I think it is important to take this into account in the planning and in the investments. And I think a lot of the investments we are seeing now in COVID, I mean, it's the biggest time, it's the first time that immunization is has ever reached such high political levels. Nobody talks about measles or cholera vaccines in normally. Secondly is the issue of the investments that have gone into the different cold chain. They are available for routine immunization. Community engagement, risk communication. These are all, we cannot just talk about COVID vaccines, but we have to talk about all the vaccines. And going forward, we already now seeing countries are integrating their campaigns with polio vaccines, with measles campaigns, etc. So integration is a way forward. And of course, in the end, the COVID vaccines need to be hosted somewhere. They're going to be hosted by the primary health care system. So investments going forward need to go more and more into stronger primary health care systems.
Ben McCormick?
I think if Stacey's here, I think she was going to volunteer an answer.
Okay. Stacey?
Nope, this is Stacey. Can you hear me?
Yep.
Loud and clear.
Fantastic. So just to echo everything that Benjamin said, but I think it gets again back to some of the things that are at the core of Priority Vax, which is the extent to which we have this opportunity now to really sort of understand how we need to tailor solutions within each country. We've had all these new investments. We've got new opportunity to take advantage of some of the elements of strengthened awareness, strengthened infrastructure systems. But then we need to really think critically about what kinds of priorities within countries need to drive where they go with the opportunities that exist in routine immunization, but especially in life course immunization, because we have many parts of the world where populations that have not previously been targeted for immunization, largely most of the adult population, that now we need to be thinking about how do we capitalize on that? How do we leverage that moving forward and use this as an opportunity to introduce a range of other adult-focused vaccines that can really be transformative in terms of changing health outcomes, and thinking about how each country is going to prioritize around that in the future.
Great. I'm still looking at the chat box for our audience to ask questions of the panelists. And while I still wait for those, I saw Benjamin had a bunch of questions for Stacey and Ben. Benjamin, would you like to voice over those questions, or can we give Ben and Stacey an opportunity to respond to them? Maybe let me ask Benjamin to voice them over.
Yeah, no, I think it's a great tool. And I think I just want to put down some of my experiences from having worked on this allocation and demand and planning for COVAX. So just put some observations, and I see a lot of resistance in countries to go to new vaccines necessarily. It's not because of the entrenched investments and experiences that people have built up. So that was a little bit of my reflection, and also the ability to access some of the maybe better vaccines is not there because of the supply channels not yet fully working, and it's not like every vaccine is available through every supply channel. So that was my point. Yeah, thanks.
Any quick responses from Ben and Stacey?
I think that's a very important point. I guess issues of switching might be that there's a sense that we've got this vaccine that works, so we keep with it. I guess that you would hope that that's a live discussion, and that process is reviewed as evidence becomes available, or you find that different products are available, and so you can then review that decision to stick with one product. I think accessibility is it's obviously a huge challenge, and in fact that could be included as an attribute in an analysis to say, well, are we able to switch, or frankly this vaccine that we would like is not available, so it can't be prioritized as highly.
Stacey, you had come off mute.
Yeah, I was just going to say that I think that's exactly what a tool like Priority Vax is designed to try and address. It's to say, if there are new options, how do those new options compare to where we are right now? And there's a lot of conventional wisdom that goes into thinking that what you have right now is the best solution. But if you really if you sort of, again, what's behind something like Priority Vax is to allow you to step back and say, all right, well, what do we really value in this decision-making process? What are the key things that we need to be worried about, whether that's cost or accessibility or even, the route of administration, a wide range of things. This is where you can actually look at that newer option, compare it to the old one, and you might be surprised by what you find, and it can help begin to sort of move decision making into a space where you're really defining it based on key characteristics that are important to your delivery system, as opposed to the just kind of sticking with what you know, which is just human nature.
Stacey, if I'm sitting in Pakistan, like Dr. Saeed on the call is, and I've been listening to these presentations, I'm thinking, what are the important factors to consider to reach country vaccination targets? You've spoken to some of them, like cost and so on, but are there specific factors maybe that come to mind immediately? And this is also a question for Ben and Benjamin, that one should be considering when trying to organize around reaching country vaccination targets.
Well, I think my view is that targets need to be reviewed, and we know more about the pandemic, and the 70% target is a global target, and countries already have different national targets, but even the national targets need to be maybe become a bit more specific. It's not really, you don't need to get 40 or 50% of everybody. You need to get 100% of your health workers, and you need to get 100% of your elderly populations. Who cares if you've got 40%, but don't miss the people that you really need to reach. So I think there is a big move going forward next year, especially to really target the vaccination more. That needs investments into systems like I showed on one of my slides, we don't have the systems, or not all countries have systems in place to identify elderly populations. Not all countries have a full register of all the health workers. So I think there is investments that need to be done, and then the vaccination strategy needs to be adapted going forward to reach them. And then the question is, like, how do we move away from a campaign mode towards then targeted immunization strategies, through fixed sites, maybe with a bit of outreach, but really community engagement to reach those populations regularly going forward, potentially. Over.
Great. That's a great place to leave it and the conversation. I see we're almost at time. So I want to just take this opportunity to thank the panelists, Benjamin, Ben, and Stacy. Thank you for your time and your insights. This has been a very valuable conversation. And also thank you to the audience for making time to convene with us and have this discussion. But before you go, if you can stay a minute or two, I'd like to invite my colleague Liz to give you next steps and highlight some events that we have coming up. Liz?
Great, thanks so much, Nook. And just a few next steps. I know we only have about a minute left. One, we do encourage you to take our post-session survey today to give us feedback on this session, and then that will inform future sessions of the series. We also have a COVID listening and learning series learning group on our Boost platform, and I believe my colleague Aisha is sharing all those links in the chat box, so we do encourage you to continue the conversation there. And then we also have a Telegram channel in which we share out announcements of future events, including events in the series. So again, encourage you to join the Telegram group. And then of course, if you have any other questions or concerns, you can always reach out to us at info@boostcommunity.org. Next slide. And just to note, we have a few upcoming live engagements that we encourage you to attend. One is next Friday. It's part of our Bright Spot series, and this session will feature leveraging the power of storytelling to increase vaccine demand. And then on June 6th, the following Monday, we'll be introducing the Immunization Agenda 2030 scorecard with our friends at the WHO and IVAC. And then on June 14th, we'll be hosting an event as part of our Behavioral Science Immunization Network. So we do encourage you to join that learning group on the Boost platform for more information about that event. And with that, I think I will just go ahead and thank all of our panelists again, and thank our participants for joining us this morning or this afternoon. Thank you, everyone.